I now invite Professor Surinder PANDAV to give his talk on lessons on surgical management of glaucoma.
Thank you, CUS. Thank you, Amit, and thank you, Parul. Uh, I'm supposed to give 5 lessons in 7 minutes that I learned. So I'll straightway go to the first the lesson that I learned. The patient selection is very important. The decision of surgery should be individualized, and of course, we had a kind of comply with the list of indications and contraindications. But what is more important is the talking to the patient, the counseling with the patients. Glaucoma surgery is a little bit different, and all patients they have actually more expectations from surgery than from when they undergo surgery. And you talk to the patient for 5-10 minutes, whatever time you have, and the parting comment is always, "But I'll get back my vision, right?" And then you think, "Oh my God, I have to start over again." So I think that's very important that you talk to the patient again and again and explain to them that surgery is something in glaucoma is not restoring vision like cataract. So I think that has to be made very clear. The second thing is they don't hesitate. So that actually generates a little bit of hesitancy in doing surgery, but I think don't hesitate when you have to go in, you have to go in. So we follow our kind of a protocols for surgery, and you have indications. But again, important thing is the threshold for surgery need not be necessarily high. And this I learned from one of the studies we did as a thesis, actually, and we looked at our patient who went blind, and we found that the risk of blindness, the rate of blindness were higher in patient where surgery was delayed or there was a longer interval between the diagnosis and the surgery. So I think that we need to know. So earlier, the threshold used to be low because there were hardly any medications. So when I started practice, basically, we had pilocarpine and timolol, and that was the end of it, and then there was surgery. But after PGAs were introduced and many other molecules came in, and so the surgical rates have gone down all over. But again, now we are coming back to MIGS now. So we are entering, doing surgery a little earlier at a mild to moderate, stage. So again, our threshold is actually going down. So that actually is a good sign. Even though there's no clear literature to suggest the surgery versus medicine, if you do early surgery, there are benefits. But overall, I think there's a suggestion in the literature that earlier surgery perhaps give you a little better outcomes on the long-term basis. The third thing is to must understand wound healing when you are doing glaucoma surgery. And the wound healing is a very well-organized, kind of a cascade of events. And it starts immediately after the surgery. You have the blood clotting, and then the inflammation comes in. Then you have the proliferative phase, fibrosis, and then the wound remodeling happens. So this process should be over in about 7 to 10 days normally in the normal conjunctiva, but that doesn't happen in glaucoma patient, unfortunately, and where the glaucoma wounds actually never heal from a practical point of view, and they keep on evolving over a period of time. So there would be exaggerated response, dysregulated inflammation, extracellular matrix deposition would be more than what you otherwise expect, excessive fibrosis. Then there's a bleb there, there's a IOP within that, there's a pressure within that, so the mechanical factors also contribute to this. So I think this is a very complicated process, so I think that has to be kept in mind. And when you are managing these blebs in the post-operative, don't think that these wounds are going to heal normally. They are not going to heal normally, and you have to intervene from time to time. So to give an example, these are two identical traps that I did about 15 years ago. And on this second day post-operative, exactly the same procedure, same surgeon, very similar patients. And the first day 2 outcome is actually very similar. Goes forward 14 days, and you can see there's dissimilarities are starting to appearing. And in this stage, many times I ask the audiences actually which bleb you think is behave better. And answer always is the B, because we are taught that there's a little less vascular, diffuse bleb will be better, but actually that's not the case. This is how the bleb evolved after 8 weeks. The bleb which was more vascular actually gave a very beautiful bleb, 12 millimeters of mercury pressure, very diffuse bleb, but the other bleb became a tendon cyst with high pressure. So I think you have to monitor these patients very carefully, because the wound healing is different in every patient. And that is what makes glaucoma surgery unpredictable also, and very challenging as well. The fourth lesson, I would say, the monitoring post-operatively. So that is related to the previous one, that we must have a regular follow-up after surgery. We have to monitor the IOP visual acuity. We have to look at the blebs, their morphology, and also manage complications if there are any, like shallow AC leaks, choroidal. So I think all these things should be promptly dealt with. The fifth is be prepared for new challenges, because sometimes the surgeries are very difficult. With multiple surgeries, you have inflammation around the surgery, maybe a uveitis patient. The complication will happen, but important thing is to balance the risks and benefits and deal with complication very promptly. And related complications, they can happen not only early but also late. So here we have an early bleb leak there, and the upper picture is actually after 3 years, the bleb is still evolving. So that's why I said the trabeculectomy blebs, they don't heal, they keep on evolving, and complication also can happen later. So this is the bonus, or the sixth, I would say, lesson, that the learning is constant. And I started with my journey with trabeculectomies in late 80s, and then came my MMC, so we had to learn the use with hit and trial, and we burnt our fingers many times. Then suture lysis came, then came the releasable sutures, which was a bigger relief, and then came the tubes. So we learned different kind of the tubes that were available to us, and now we are grappling with the MIG procedure. So last 3-4 years now we are learning different kind of the MIGs. So I think last 30 years, it has always been, surgery has been evolving, and we have always been learning new procedure almost every few years. So that was my take on this topic. Thank you very much once again.
Thank you, Professor Pandav. One thing that I've learned from Professor Pandav, I've trained under him, is the extreme amount of tissue respect that Sir has. So how he handles the tissue dictates the outcome, and that's something which, as surgeons, most of us don't, practice, although we are all aware of it, but we don't practice. So very, very essential pearls has shared, and I hope we all learn to follow up our blebs just like newborn babies, and of course the outcome would be much better. So thank you, sir, for such an insightful talk.